Hi, I'm Dr. Martin Rutherford. I am a chiropractor, 35 years or so, and I am also a certified functional medicine practitioner. This is
Dr. Randall Gates. I'm a board certified chiropractic neurologist as well as being a chiropractor.
And each week we handle a different topic that we think that the lay public out there will find interesting. There's a lot of confusing issues relative to chronic pain. Dr. Gates and I each have paradigms of care that are quite new. We've married the paradigm of functional medicine that deals with the chemistry, which we're going to talk about today, in a very exciting fashion.
Action-packed.
Action-packed, I think it was advertised that. So we'll try to make it action-packed. But we're going to talk about the chemistry of it quite substantially. And Dr. Gates is a board-certified chiropractic neurologist, which has morphed into functional medicine. I did quite a bit of reading about functional neurology about that the other day. We're trying to be very careful about how we articulate what we do. And so the combination of two has caused us to develop a largely chronic practice, chronic conditions, chronic pain, chronic everything. Right? 95% of our practice are fibromyalgia and peripheral neuropathy, and chronic fatigue, and a lot of neurological problems, dizziness, vertigo, balance, restless leg. And interestingly enough, these are full body problems. They're not as specific as most of us, and I have several of these problems. Most of us were led to believe by our diagnoses. And so we're going to talk about female pattern hair loss today, hirsutism, and congenital birth causes, genetic causes of increased testosterone in females, because this subject, not unlike thyroid problems, not unlike bowel problems, which we're all going to talk about,
right,
we found are completely interconnected and interlinked in many, if not all, of the conditions and more that I just got done mentioning. So for those of you who are specifically having these types of problems as we talk, you might find that you have other conditions that you might get some surprising data on. But let's get to the exciting subject of female pattern hair loss, hirsutism, and congenital causes of increased testosterone in females. So why are we talking about this? Well, partly said why we were talking about this.
Yeah, exactly. And I think we need to talk about the evolution of how we came into this. I think so. We started out treating primarily neurological patients. Dizziness and vertigo, fibromyalgia, that's where they have pain all over their body, peripheral neuropathy, that's where people have numbness and tingling and burning in their hands as well as their feet. And we noticed that many of our patients who had never been able to lose weight were now losing weight.
Ah, okay, that's true. That's true. I did an article one time because I was up against the deadline, and the article, and I didn't have an article, so I thought, oh, let me write on the 7 reasons. I was probably right. 7 reasons why people will never lose weight, because we weren't treating people for weight loss.
Right.
But everybody was coming in here who couldn't lose weight no matter what they tried.
Started losing weight. And then started telling their friends how good they felt, and their friends saw how good they looked, and so then we kind of had this weight loss practice evolve in addition to everything else we do. So this is an emotional issue too, because there are many women out there that we encounter who work out 6 times a week vigorously. They're eating a clean diet. They're doing everything right. And their husband still says, well, you're eating too much. Or somebody will say, you need to count your calories. And they want to pull their hair out because they're trying all that.
But they listen to Dr. Koop that he says you need to just exercise 15 minutes more and cut your calories another 25%.
Right, yeah.
And he's the radio guy for those of you who don't know. And when I hear him say that on the radio, I just envision tens of thousands of women throwing things at the radio or throwing the radio out the window or something.
Exactly. Because in the studies, they will say stuff like that. If you exercise, it will help the testosterone to come down. We're going to talk about that extensively today. However, in the people we see, the patients coming into our clinic, they have tried that. We have had women who weighed well over 400 pounds who were working out 10 times a week. And
one patient ride a bicycle 20 miles a day, every day for a year, and lost, I think, 10 pounds.
Right.
And she was probably about 80 pounds overweight.
and eating a healthy diet,
eating
whole grains, you know, all of that stuff. So we're going to get into those nuances, but that is the general framework for why we're talking about it, because frankly, it's semi-heartbreaking to interview a patient who's been struggling for years out there, trying to lose weight or dealing with facial hair growth or dealing with their hair falling out or dealing with chest hair. And it seems common that it's not really addressed. So typically in the mainstream medical field, and we're not being denigrating, we're not derogatory to our medical doctors out there. Most of our friends are medical doctors. We have great appreciation for what they do, but you have to realize that we all have an area that we focus on. We all have an area that we're really good at. As I was saying to a patient yesterday who flew in from Cleveland, Ohio to see us, if your arm is falling off or your arm is cut off, don't come see us. If you're having a heart attack, don't come see us. But if you have one of these chronic issues, it may not be a bad idea to come see us, because this is what we do.
And in case you missed the link there, the reason we're talking about weight loss is because the same thing that's preventing you or many people from having weight loss are the same things that are causing you to have this excess hirsutism or the female pattern hair loss. And if you had blood testing, the high testosterone levels. And just again, we've been invited Saturday morning at 8 a.m. Maybe we don't need to go now. Maybe we'll just tell them to watch this. But to tag on to Dr. Gates' comment of it's not really handled well or at all, frankly, in the medical profession. It's these laser hair removal places all over the country. I mean, this is their patient population, right? Getting bleached and getting the hair out and getting it out of the chest and so on and so forth. And so they read an article that we wrote and called us and said, listen, we'd like to know what we can do with these folks. Or can we send them? Or what type of testing can we do? There's several nurses that work there. So we're essentially practicing for Saturday morning, right? Okay. So anyway, but
which I didn't even know. I forgot.
He didn't know. I had asked him before. So this is one of those cosmic things. So probably what we should do is define each term here: female pattern hair loss, hirsutism, and then the congenital aspects of your testosterone increasing, which we're going to talk about quite a bit here because it's a big part of all of this.
So female pattern hair loss, basically, it's when women start losing hair. There's a characteristic pattern. Usually it's on top. Many of you may have this. A lot of women we have come into us who say, oh my gosh, my hair is falling out. You know, it looks like we skinned a raccoon in the shower every day. You know, those are the comments.
Extreme manifestation is the person comes in and just has strands of hair left on their head.
And in women, as opposed to men, it's like 70% of the time, I believe, it's due to elevated testosterone, specifically dihydrotestosterone. But in women, 50% of the time it's testosterone, which is a big percentage because we have to screen women for autoimmune issues when they're having hair loss. We have to screen them for thyroid problems, Hashimoto's thyroiditis, that's where the immune system kills the thyroid. There are really a number of conditions that can cause it in a female, but still testosterone accounts for half of those cases. And so that is a big deal. And we're going to talk about where the testosterone is coming from, whether it's congenital, whether it's a developmental issue relative to obesity, or whether it's an issue of a receptor issue where the testosterone may be binding to your receptors a little too easily. So
we might talk about your intestines.
Yes, we probably will talk about intestines at length.
I just said that out there because people were like, when I start talking to them about this in our consults, like, my intestines, what's the second to do with that? You're about to find out. It has a lot to do with a lot of this. So I guess the next step would be to talk about where does testosterone come from. We have, a lot of people just accept this as normal, by the way. I mean, they because it's never addressed or even mentioned in the medical model, and because it's really not connected to insulin resistance. In an article that we wrote that got the telephone call, we received a telephone call from the laser hair removal people. I started out by saying most people won't diagnose somebody with PCOS, which I assume we're going to talk about, polycystic ovarian syndrome, which causes a lot of these symptoms, okay? Unless the person weighs 300 pounds and is growing a beard. Yeah. And I forget where we got that from, but it was.
I actually heard it from your neighbor, I won't say. but she was a gynecologist.
Oh, right. My neighbor, exactly.
Right. And nothing against her,
she's
but that is really how they look at it.
And she's a female gynecologist who happens to be a very dedicated gal.
Oh, wonderful.
Very cool, very good doctor. That's right. And that's where, and it was such a vision, such a something that you could picture that I've used that multiple times, and people relate to it because they said, well, I thought it was normal. My doctor just, they didn't say anything. Mm-hmm. And we're probably going to get a little bit into polycystic ovarian syndrome. So I'm going to leave Dr. Gates to kind of talk about where the testosterone comes from and all the different things that can create a pattern of high testosterone in a woman. And I'll just say, when women have high testosterone, a lot of things happen to them and their physiology, and none of them are good. Mm-hmm.
Right. So basically the testosterone can come from the adrenal glands. And this is an area that really needs to be talked about. So it can be a genetic issue. And
the adrenal glands are?
The adrenal glands are the stress glands. Thank you. So, and you may wonder, why is the neurology guy talking about this? Because the brain's influence in talking to the stress glands is important in these issues. A lot of our patients have been through tremendous stress as children, unfortunately, abuse, sexual, psychological, physical, on and on. It's really, really common. Now, the stress glands are designed to make several different hormones. They are to make cortisol. Many of you have heard of cortisol. If you've seen the commercials, late night TV, stubborn belly fat, take lipozine, they're talking about blocking cortisol there. The adrenal glands also make adrenaline. So if we're stressed out, we're going to be able to make adrenaline to allow our muscles to contract harder and for our heart to pump harder and our lungs to dilate, or bronchioles to dilate, all of that. And then the adrenal glands also make things like testosterone. They make estrogen derivatives, progesterone derivatives. The testosterone derivative specifically is DHEA, which you need to be familiar with out there if you have any of these syndromes that we're talking about today, because in certain individuals who have things like female pattern hair loss, hirsutism, or congenitally elevated testosterone, there can be an enzyme defect. An enzyme is just like a catalyst that is helping these reserve hormones go into cortisol and estrogen and progesterone and DHEA. And there can be an enzymatic deficit. It's called the 1720 lyase enzyme, where you may start producing too much of your reserves into DHEA. And that can be the source of this testosterone. Now, there are medical conditions you and I talked about one a couple years ago. Congenital adrenal hyperplasia can affect males or females. And a female can cause a severe syndrome of excess testosterone. And basically, you're going to see that their testosterone is over 200, which is about what a man with low testosterone would have. Right. And so there are ways to diagnose that. Sometimes you have to do a CT scan. Clinicians have to be aware of it. That's all I'm saying. But basically, it can be not as pronounced as congenital adrenal hyperplasia, where basically the body is just making too much testosterone over a long period of time. We test all of our female patients for their DHEA levels.
Yeah. And again, just to maybe put in a little perspective, your adrenal glands they hold the precursors to making all of your hormones, pretty much all your hormones. Right. And what that means is that your adrenal glands, combined with other things, Dr. Gates talked about enzymes and stuff like that, combined with other things to make not just testosterone, but progesterone and things of that nature. Okay, other hormones. And there's and he alluded to stress also. So there's something called a pregnenolone steal. Pregnenolone is one of the precursors. One of the things that Dr. Gates talked about that combines with other things like cholesterol. We won't get into that, but combined with it, and they make hormones. If you're under a lot of stress, and other things that happens is those precursors that are to make your hormones properly are used to manage your stress. Right. And then you can't make estrogen, or you can't make certain things, and then that can lead to some of these imbalances where you can have not enough. This is one of the most common causes of females having all of the different female symptoms that they have.
Right, and I even attached an article on this.
Okay.
And basically they're talking about cortisol resistance.
So that's why the adrenals are so important.
They're very important.
In people who have female pattern hair loss on top and or too much hair everywhere else. It messes up that chemical pathway. And we're going to talk more about that.
And yeah, one thing I don't think I explained was what hirsutism is. If you're watching this, you probably know what it is. But basically, that's where a female starts to get hair growth in a male pattern, basically on the face. Okay, good. And that can be basically due to the elevated testosterone or the testosterone receptor. But where's the testosterone coming from? Another option is that it's converting from your estrogen into testosterone. Lots of times due to obesity, lots of times due to this metabolic syndrome. We did a whole talk on metabolic syndrome. You can access that on our website. And basically that will cause the conversion of your dominant hormone into your non-dominant hormone. And that can be a source of this issue. In men, just the opposite happens. So you see the guys who are big, they have the big belly, and they can start to develop breast tissue because they're taking their testosterone, converting it into estrogen.
So I think the layperson would probably cognite more relative to maybe if you have insulin resistance.
Okay.
If you're pre-diabetic, then Dr. Gates was talking about metabolic syndrome. If you're pre-diabetic, there are pathways that will change your estrogen into testosterone.
Mm-hmm.
And that's what Dr. Gates is saying. So you may not be connecting the fact, and you can talk about a couple of different ways that people become pre-diabetic. And so this pre-diabetes, that is called Syndrome X, metabolic syndrome. I'm mentioning these because medical community is starting to talk about this, and they're starting to, but they're utilizing medications and to try to control the blood sugar. But the bottom line is if your blood sugar, even though you're not a diabetic, if your blood sugar is to a point where they have called you pre-diabetic, insulin resistant, syndrome X, metabolic syndrome, they're all basically the same thing with some small variations. You are very, very likely changing your estrogen into testosterone, and then that is going to create the patterns of too much hair on your lip and on your chin and on your chest and so on and so forth, and too little hair on your head. And that's not really, that really is kind of, I think maybe cognite more with.
Okay, perfect, absolutely.
With a lot of the folks that we're talking to right now. So we're trying to walk a line between talking to the lay public here and talking to some of the professionals that we've become aware of that are watching the programs. And sometimes we're apparently lean too much towards the lay public for the professionals, and sometimes we lean too much one way for the other. So
yes, it's a tough bridge to get.
Yeah, it is. Well, we're really here for the lay public professionals, just to let you know.
So then we need to talk about the pre-diabetes and where it's coming from. So the new data on this, and it's so incredibly exciting. It's just the most exciting thing I think this year. And that basically,
I would agree. We've had a couple of 2 or 3 exciting things this year, and that's definitely one of them.
Right. Yeah.
And when we say exciting, these have been breakthroughs that have come to us through his diligent research and through some of the mentors that we know, having gone to some of their seminars. And,
well, we won't go through a specific case, but basically what they're now seeing with this insulin resistance or pre-diabetes is that there can be an overgrowth of bad bacteria in the gut, and that pieces of the bacteria go into our bloodstream. In essence, the pieces of the bacteria are there in too high of an amount or too high of a quantity, if you want to think of it that way, and that specifically causes insulin resistance. And then that insulin resistance then creates this vicious pathway of a person gaining weight.
You changing your estrogen into testosterone.
Yeah, and then that will cause a conversion of estrogen to testosterone. And then also that fat that we get becomes an organ unto itself, like we talked about in previous videos. So now that changes signaling patterns back to the brain in terms of when you're hungry and when you're not hungry, and then people tend to get more hungry.
Right.
The bigger they get.
Right.
And they
it's a complex mechanism, the body.
Yes.
However, those of you who would be interested in what Dr. Gates just got done saying, particularly in my experience, are the ones who come in to our office and say, okay, I'm exercising every day and I'm eating really, really, really good. And my blood sugar is high. How could your blood sugar be high if you're eating well and if you're exercising? One of the best ways to control your stress and your blood sugar, because your adrenal glands have a lot to do with controlling both of those, and both of those, particularly the particularly the exercise really helps your adrenal glands. But if you're coming in, or better yet, if you're coming in, you're eating pretty well and your blood sugar is high and you're taking a blood sugar medication and it's not going down, the answer is not a second or a third medication. This is usually going to be the answer. It's coming from a source that's not being really yet acknowledged because it's, as Dr. Gates said, it's pretty exciting. This is something that just came out very recently.
Right.
And when Dr. Gates and I were exposed to it, he ultimately does all the treatment here, and he ultimately utilized that data on a couple of patients, and immediately you saw a change in their ability to lose weight and changes in their patterns coming from your small intestines.
Exactly.
Yeah, coming from your small intestines.
And where do we go with that? Basically, you know, when I'm reading a lot of these research articles, they try and research to do one thing at a time. That way they know, okay, this treatment had this effect. And you know what? Unfortunately, in clinical practice, we have the reality of we have to produce results now. So we kind of have a multi-systems approach where we're doing a lot at once. We do have an organized framework to generally know what is causing what. But basically, you can't just drop testosterone in a female and say, okay, let's see if they lose weight. Those studies haven't worked. Just like, you know, this dietary intervention may not work, or this exercise program will work for some people, but won't work for others. I mean, that's basically what I look at. Because we're all different. There's complicated mechanisms going on in the body. It's such a vicious cycle, you know, just to kind of envelop what we've already talked about today. You're talking about maybe producing too much DHEA from the adrenal glands, coupled with that, leading to some obesity, coupled with that, having some small intestinal bacterial overgrowth. Now with your obesity, you're taking what estrogen you do have and turn it into more testosterone. And then couple that with you're stressed out and your cortisol is not feeding back properly to your brain, and that's throwing off your leptin levels even more than your obesity, things we haven't even talked about. So now you're eating more than you should.
Yeah, and
that's how complex this mechanism.
And a very simple example of what Dr. Gates is saying relative to research, because I've been in practice since 1980 here at Reno, 1979 altogether. And I think the debate based on research on how much salt we should eat or not eat has probably gone back and forth at least 6 times. Or you should eat salt, you shouldn't eat salt. You should eat a lot of salt, or you shouldn't eat salt. It turns out some people should eat a lot of salt. And it turns out some people should never put a salt shaker on the table, correct? You know, so I mean, what I'm saying there is you have to take research with a grain of salt when you're in clinical practice. People are coming into clinicians trying to get better. And frequently, I read the other day an article, frankly, on functional neurology. And the debate on functional neurology, and one gentleman went into pages of what should have been done to prove that functional neurology methods work. If you came to our practice and you sat here for a week, you wouldn't need a PhD to figure out that functional neurology methods work. And you know, to a large degree, we need to get back to that. And the people who are researching these types of things, to me, are the heroes, because they have to combat all of that criticism. Oh, it's not scientific, you haven't gone through all that. By the time somebody figures this out and makes a drug for it, it's going to be 10 or 15 years down the road, and the drug is not going to be able to handle these cases consistently, because every step along the way that we have talked about relative to, it could be your gut, it could be small intestinal bacterial overgrowth, it could be too much stress, it could be insulin resistance. That's truly insulin resistance. That truly is, you know, pre-diabetes that needs to be handled through time. It could be any combination of those. How are you going to put that in a study? Right. You're not. Right. You are not going to do it. We've all who've gone through school have been exposed to how to do experiments and how to do controlled environments. And I think we run as controlled environment as you can based on these principles. And what we're telling you, you can take to the bank, because this is the type of an approach that can help you. That can help you out. It'll be interesting to see what happens Saturday morning when we talk to this group, because they're all nurses, and I think they're going to have a hard time when we tell them, but we'll see. Maybe we won't tell them to watch this. Yeah. So the point being that what do the MDs do? I guess the next thing is you come in, you have. Basically, I don't know that people go to medical doctors and say, "Doc, my hair's going out." If their hair's going down, a lot of times they're gonna they're going to look for thyroid.
Right.
You'll find that the medical doctor will look for thyroid. You'll rarely find them looking for adrenal problems, stress. You'll rarely find them looking for any gut problems. I don't think you will have them looking for that at all. They might do a hormonal panel, find out that your testosterone is high, and then do what?
Put you on spironolactone, sapropterin acetate, finasteride. Finasteride is what they use for guys with prostate, to basically just block testosterone or drop it.
Exactly.
That's basically what their approach is going to be. And
in the meantime, all these other mechanisms are still working.
Yeah.
To create high testosterone while that's happening.
Right. So it's basically just, it's not peeing on the forest fire, but it's. Yeah, that's what it is. Basically it's just a little water on the forest fire. It's not correcting the underlying cause. And that's where, when we did the PCOS talk, we had a lot of feedback in the PCOS talk because it's an emotional issue. And this is an emotional issue as well. And hopefully we get that across because we know what you're suffering with out there. Yeah. We don't know personally, but we hear your stories all day long and we feel for you. And I was thinking about it walking in my car this morning. I was just thinking, man, how do we get this across to those females out there who are suffering the ridicule, who have the judgment from their husbands? By
doing what you're doing.
Yeah.
And we didn't even really hit on PCOS, the fact that I had a lady in here yesterday. I've had 2 in this week, and it's Wednesday morning. I have 2 in this week, can't have a child. They've been diagnosed. Their history they have ovarian cysts. Okay, what's that got to do with all this? If you have high testosterone and you have polycystic ovarian syndrome, you have cysts in your uterus, you've had your uterus out or whatever. I think that the statistics are that PCOS is the leading cause of infertility.
And it's the leading cause of elevated testosterone.
And it's the leading cause of elevated testosterone. How much percent?
70%.
Okay, see, and I was going to say
high testosterone have PCOS. And that's where I want to go next too.
Cool, then go there, because that's when it really becomes emotional. Because what I was going to say is that's when this lady really kind of broke down. And she did mention that her husband maybe wasn't as understanding as she thought he could be, in the fact that she was eating well, and in the fact that she was exercising, and that she would just cry. She would just go home and cry at night because especially those of you who are really trying. I mean, you're really taking responsibility. You're reading all the books, you're doing the right diet, you're going out, you're exercising, so on and so forth. It really is. He's had a personal experience with it.
Yeah, I just thought back to something.
It's actually an emotional, I can already see it. It's actually an emotional.
I'm not sure enough, but I thought back to, I had a relationship with a gal when we were in college. At one point she said, well, I want to lose 5 pounds or 10 pounds or something. She was working out all the time, eating right. And I said, do you really think that's going to happen? I mean, you're doing all the right things. Maybe this is my karma, so to speak. I'm not going to get spiritual on anybody out there, however you want to say it. But basically, yeah, for those of you out there, a lot of us like to think we know a lot about a lot. And lots of times people may not know as much as they should about what they're voicing an opinion about. I can say that out of personal experience in this circumstance. And basically, for those of you out there with polycystic ovarian syndrome, the way it's diagnosed is you have abnormal menstrual cycle lengths, you have too much testosterone, or you have cysts on the ovaries. You have to have 2 out of those 3 criteria. And basically what we know of polycystic ovarian syndrome patients is that there is a huge prevalence of metabolic syndrome, insulin resistance, prediabetes, inability to lose weight with all these issues, coupled with infertility, which is the real big kicker. So then the medical treatment is basically to put them on diabetes medications to control the insulin resistance, to put them on testosterone blockers like spironolactone or finasteride or one of those, and then also to put them on Clomid, which will cause the ovaries to make more eggs, or basically it causes you to have more estrogen going to the ovaries, and the ovaries to make more estrogen. And that is the medical treatment for it. And it can work in certain circumstances, but as you were relaying with those females, they've likely been through those treatments. And we had a gal who weighed over 400 pounds who had been through that treatment, and it didn't work because all these underlying issues were going on. By the way, that gal who was 400 pounds, who worked out 10 times a week, who couldn't lose weight, is now upwards of 50 pounds of weight loss. And largely it's because we have finally, these breakthroughs that we're talking about have led us to this year fixing her gut properly, getting rid of the bad bacteria that were causing her insulin resistance. We work with other medical doctors and we collaborate in certain circumstances to block the testosterone with nutritional supplements that also block the testosterone. We have found that to work really well. And you have to keep in mind that your medical doctor has to be really attuned to changing the dose on these testosterone blockers. I've seen it just from a third eye standpoint, so to speak, to where, you know, a certain quantity of that testosterone blocker may not work and they may need a little bit more. And then all of a sudden the weight loss starts after that. So that's the medical approach versus the natural approach. We're gonna get more into the natural approach as we go through this, but basically.
And didn't you also work with that lady's DHEA?
Yeah, exactly.
And I'm only saying that to try to draw attention to the fact that Dr. Gates just mentioned 4 major biochemical pathways that needed to be addressed. And all of these create female pattern hair loss and too much hair on the face and the chest and other places. And frankly, in probably half, from what I've read, and correct me if I'm wrong, but probably in half of female infertility, these things are prevalent and they need to be addressed. They're not being addressed, and they're not being addressed. So, and it can be, and it can be addressed. So
no matter what your husband says, or no matter what your gynecologist says, and we're not denigrating them.
No, it's always
They're
helpful.
Very bright people, but you need to know there are solutions out there.
Yeah.
And that's an audacious statement, I know.
No, and it is. It wasn't meant to be audacious. What we're trying to do here is to very delicately indicate that there are 2 different models of care out there. One is the medical model, and it is based around acute care. It's based around pharmaceuticals. It's based around surgery. These drugs are based around boosting something, depressing something, stopping something from happening. And what had to occur to understand how to address the 120 million and counting chronic conditions out there, and this is, have no doubt, this is a chronic condition because it keeps getting worse, doesn't it? It keeps getting worse. And chronic conditions are multiple pathways that are becoming imbalanced. They're not working properly, and for the most part can be restored, but they can't be restored by one. How does one pill restore what we just got done talking about that 400-pound gal?
Yeah.
It doesn't. It can't. There isn't a person out there who knows anything about chemistry or biology or biochemistry or any MD or anybody who heard me say these last 5 minutes that could possibly disagree with what I just got done saying with a straight face. Okay. So that's all we're trying to do. We do work in an integrated fashion. I had a patient yesterday, the young man that you introduced, who's taller than you, I think. Yeah. Dr. Gates stands up, he's about 6'5". And he wanted no drugs. Once we got done talking to him, because I'm guessing he may need some thyroid, or maybe he may need an actual antibiotic, and if that doesn't work, he may need something else. But he was okay with that. But he didn't want any, he was in for depression. He didn't want any of those psychotropic meds. I was like, okay, we're good with that, you know. But we work in a very integrated fashion on these cases. And so we have to be conversant with what's going on in the medical field. We are not medical doctors, but we do have doctors who, because of the things that they saw in our common patients occurring, they reached out to us and said, we want to be part of this. It's fun. We want to see our patients get better. Fortunately, they happen to be pretty bright guys also, and have helped to fine tune some of the things that they were doing. For example, the testosterone dosing that Dr. Gates just came out. So this is a very complex issue. However, it's only complex if you don't know where to go to look for it. It's only complex if your doctor even understands that something can be done about this, and it's not some normal thing to happen because of menopause or old age or something like that, or that it can be fixed by simply blocking the testosterone, because whatever is creating the testosterone is still creating it while you're blocking it with the blocking medications. So let's go on. How do you do? So we've kind of had bits and pieces of how you do it. How do you do that now that I got him through his emotional? Now that he's back.
I did not well up, but it just hit.
But this hit you hard. I remember, and I'm not going to go into it because it's a very personal matter, but there was a point where Dr. Gates had a partner who was his wife, who was experiencing all of this, and it was in the medical field, and it made it very difficult, even with that closeness.
Right.
And it affected them both. It was a very, very tough thing. And we see it all the time in the patients that come in. So that's why we thought that this would be a good topic to address. Talk about so if somebody comes in, they have all this. Mainly, people don't come in for this.
Right.
Mainly, people come in for everything else.
Right.
They can't lose weight. They have PCOS.
They have
fibromyalgia, chronic fatigue. We haven't talked about
thyroid problem.
I was going to say we haven't even talked about the thyroid problems, which we could go on with for an hour. If you want to hear about the thyroid problems, just scroll to any of our thyroid presentations, and you'll see how these cross. You'll see how these interlock if you're interested enough that you want to go do that. So how do we go about someone who comes in with fibromyalgia and we have all of these, and we look at the patient, we examine the patient, and we see their hair thinning out, and we see that they've got a mustache that they're trying to cover up, and we see that they got belly hair and chest hair and all that type of stuff. And as part of treating their other problem, like they can't lose weight no matter what they do, we come across this. How do you go about it?
Okay, so first you have to start with the gut. Basically, that's where it all starts. And I don't care what
in
you're
the
eating.
gut, and we've only mentioned the gut like once.
Exactly.
But that's where it starts.
That's where it starts. And basically, you're going to come in and you're going to tell me, oh, I'm eating healthy. Oh, I have hardly any carbs. Well, that's fine. But we're going to put you on a diet that is going to starve the bad bacteria in your gut. And it's not a diet. You can eat as much as you want. But we're going to starve the heck out of those bacteria. And a lot of our research this year, hundreds of hours, has gone into figuring out the exact diet that good bacteria in the gut like to feed on and bad bacteria in the gut don't like to feed on. And then we use natural protocols that basically go in and try to eradicate those bacteria. Sometimes Dr. Rutherford alluded to, we have to refer a patient to a medical doctor for a medical antibiotic treatment. And in the process of that, we go in and we start to heal up the gastrointestinal tract so that fewer pieces of bacteria start to leak through the bloodstream.
And for those of you who are going on the antibiotic thing, or I want to do that. If you know what you're doing, you do a short-term antibiotics, you get rid of it. Then, because we understand what's going on, we clean up the gut, and then move on to the next step. That is a big sticking point for a lot of people.
Because some people don't want to do anything.
Yeah.
And we get that, and we don't either. But we are also realistic, and we have to produce results.
It's our last
we know how
line
to
of
produce
defense.
a result. Yes. And then we go back in and we heal up the gastrointestinal tract so fewer bacterial pieces leak through. Now, what you need to know there is that's called leaky gut syndrome, and you can bring that up to your doctor, and they're going, oh, that's a bunch of hooey-pooey. But really, in the last year, anybody who's up on the research knows that leaky gut syndrome is irrefutable now.
They're even terming it leaky gut syndrome.
Right, which we think is a horrible term.
Which irritates me. It's actually, it's
intestinal.
But it just shows you how much it's taken over the research field.
Exactly.
How many articles are there on it?
Oh my gosh, I attached like 30 to our PCOS or our metabolic syndrome one, and that was in a couple hours.
So I was going to say 100, couple hundred.
Oh no, there's more than that. Yeah. So
it's for real.
Yes, and it's irrefutable.
It's not for real. It's there.
Relative to diabetes, prediabetes, insulin resistance this year. It's been shown. So basically, there's that component. And then if we can be successful there, we commonly see that the metabolic syndrome, the insulin resistance starts to reverse. If we can get that to reverse, in and of itself, lots of times that will start to normalize the hormone patterns.
The metabolic syndrome, the diabetes. The diabetes type 2 starts to normalize and people get off their drugs.
Right. And I smile because there's another case I want to talk about that one. So anyways, I have
we're just chatting here.
I won't go into it. It's okay. I'm on a roll. So basically, then the hormone profiles can start to shift in and of themselves. So basically, the estrogen will slow down its conversion into testosterone if that pathway is going on. And then from there, we say, okay, are we where we want to be? Is the hirsutism going away? Is the female pattern hair loss changing? Are they growing more hair? We had a case come in, literally over $30,000 spent on electrolysis and hair removal treatments. Went through our protocol.
The author?
Yeah, didn't need it anymore. That's why she came in for a thyroid treatment. So anyways, there's that. And then if it's not reversing at the rate we expect, then we use natural modalities to basically decrease the conversion of estrogen to testosterone. There are natural supplements that do that. You can look into peppermint and spearmint and things of that nature. We have one that I'm not going to mention that works pretty well, just because I think we should be able to keep some stuff to ourselves. And then
it's not like they're going to take one supplement.
That's true.
Themselves.
I know what you mean. And then we also have to adjust how the brain is talking to those stress glands called the adrenal glands, because if that communication is going at too high of a rate, that can lead to too much cortisol, which can lead to excess body mass. It can lead to, if you're already making too much DHEA from your adrenal glands, if your brain's sending more signals to your adrenal glands, and that can lead to excess DHEA production as well. So that pathway has to be monitored.
Yeah, what people don't understand, and what I find I have to explain in that particular area, is that stress changes your body chemistry. And just very simply, the way it changes your body chemistry will sabotage anything that anybody is trying to do until that stress mechanism is dampened down. And that's where the functional neurology is very powerful without drugs. There's some powerful neurotransmitters that can be used, but it can be done without drugs. But that stress mechanism, trust me, if you're having hirsutism, if you're having hair loss, female pattern hair loss, and you're stressed, trust me, it's contributing. It is contributing in a chemical way.
Yeah, big time.
Yeah.
So basically, there are those components. We talked about Rob Sapolsky almost in every
the man on stress from Stanford.
Yeah, so you need to look him up and either get his book Why Zebras Don't Get Ulcers or watch his talks on YouTube. He's just wonderful. And he's the world's foremost researcher on stress, and he talks exactly about how stress changes our body chemistry in a very, I think, succinct fashion. So there's that, and then if you're making too much DHEA from your adrenal glands, and if we've gone through all that and you're still not improving at the rate we expect, then we're very realistic and we'll refer you out. We'll write a letter to your doctor. We'll refer you to one of the couple doctors that we've talked about who work in this fashion. And lots of times they will evaluate the situation, decide if they're going to use a medication to decrease the DHEA or not. That's up to them. But basically, that is how we flow through this process, and it's pretty fun.
Yeah,
pretty awesome.
And it works. And it works. For the most part, people's hair is going to stop growing in the places that shouldn't be growing. If a patient comes in and they have strings left on their hair, they're not going to grow a full head of hair back, but their hair will increase. Their hair their hair pattern will fill back into some degree. But for the most part, and again, that frankly isn't the reason most of them come in, but that's the topic here today.
Yeah.
It can be, and of course the other side effects are you'll lose weight, your blood sugar will get under control, your gut will be better, because that's what has to be done for you to be able to switch that around, and if that's something that's important to you. So to summarize.
To summarize, female pattern hair loss, hirsutism.
You have summary.
Yes, exactly.
I'm usually the one to do summary. I'm putting them on a spot.
Congenital elevations in testosterone. Just know if you're out there, and we made a lot of comments today, none of them were meaning to be denigrating or derogatory. If you talk to your OBGYN about this, you feel like you're coming up against a brick wall, know that it's not their fault. Know that they're delivering babies all hours of the night. Know that they have life and death issues of cutting out, ovarian cancer and things of that nature.
Exactly.
That's where their head's at, rightfully so. And so if you feel that maybe you didn't get the answer you want, watch our broadcast, because I feel that we're going through this. And to summarize it, just know that whether it's hirsutism or hair loss or this testosterone issue, you have to figure out where it's coming from. Is it coming from the adrenal glands? There are ways to test for that. We've gotten a lot of comments on how you figure this out. You basically test for it. There are lab tests to do that. And you need to look at your other female hormones as well. You need to evaluate, does the person have insulin resistance? Do they have pre-diabetes? Do they have diabetes? You can even evaluate what their cortisol levels are relative to the stress mechanism. You can evaluate leptin levels. Leptin is a hormone that comes from fat tissue that feeds back to the brain, that tells the brain basically whether you're full or not.
Small intestinal bacterial overgrowth,
which can be tested for. All these things need to be ferreted out. And then once you have the picture, just as we talked about in terms of the treatment, you can take a person through, figure out the right diet for them to starve the bacteria in the gut, to decrease the bacterial overload going into the bloodstream, to decrease the insulin resistance, which will decrease your body weight and decrease conversion of those hormones. And then you figure out, is that enough in and of itself, or do we need to use something natural to do that? And if that doesn't work, then the person needs to be referred to a medical doctor to have the potential of the adrenal issue to be evaluated and see if there's a medication that will work for that circumstance. That's basically the flow.
So my summary will be, if you have female pattern hair loss, hirsutism, and or high testosterone, I realize those can create emotional issues, but just understand there are a lot bigger fish to fry in your physiology if you have those indicators. And once you get those under control, you can start feeling pretty good.
I like it.
Yeah. All right. So I think that really covers it.
Mm-hmm.
That was a lot of data, and I'm sure Dr. Gates attached 200 references. Only 20
yeah.
to it. For those of you who are a little bit more scientific minded or inquiring or know how to read studies or would like to confirm whether what we're saying has any backup or validity, they are attached. So I think we have handled that in a very conclusive and comprehensive fashion. If you have any questions, like Dr. Gates said, the polycystic ovarian syndrome broadcast got quite a bit of feedback. Dr. Gates will make every attempt to communicate with you and answer any questions you might have. This is a unique field, so we're happy to help you to try to understand these things. And you would do that by contacting powerhealthtalk.com
or our Facebook page.
And Dr. Gates will get back to you as he is able. He's quite busy, but I'm pretty computer illiterate and he's the guy. So there you go. So until next time, I hope that is helpful, and hopefully we'll have another exciting action-packed presentation for you.
Thank you for watching.